Post-transplant cyclophosphamide, I think most people would agree, has been paradigm shifting in terms of in the realm of GvHD prophylaxis. This was based on the work that came out of Hopkins at our center. I wasn't a part of it. It was well before my time. But we had a host of patients who got the PTCy-based GvHD prophylaxis for their transplant for myelofibrosis, which in and of itself is a fairly challenging disease. So we thought it was worth sharing that data with people. Now, we had a fairly unique cohort of 31 patients, relatively small, but an interesting cohort in terms of the fact that most of these received a non-myeloablative conditioning with flu-cy and TBI. That was around 80% of them. Around 60% of them were haploidentical donors, which is, again, a rather undescribed donor category in myelofibrosis. And most of these received a peripheral blood transplant, which was around 60% of them. And with that platform, we transplanted 31 patients with mostly intermediate 2 or high risk myelofibrosis, which is as expected. A lot of them had big spleens at transplant and so forth. And this was over a period of around 10 years. And in our cohort that we presented, we showed that around 90% of them achieved engraftment. There were around 10% graft failures, including the people who got a lower dose of radiation and got a marrow graft, where we have seen this to be more common. And we showed that at 1 year, our overall survival was around 72%, which is fairly comparable to some of the other data that has come out of CIBMTR in the past years and so forth. At 3 years, this overall survival was 63%. We had, due to our non-myeloablative regimen, our non-relapse mortality was what I think fairly low at around 10% at 3 months and around 20% at 1 year. The GvHD rates, especially for grade 3 to 4, were 10% at 3 months and 13% at 1 year. Chronic GvHD rate overall was 18% at 3 years. So fairly manageable in terms of complications. As you've seen in other studies, when you trade off non-relapse mortality, you trade that off with relapse. So our relapses were on the higher side. I mean, they were only 10% at 1 year, but by the time we reached 3 years, we had around 40% relapse rates. Now, that has been a fairly common problem with myelofibrosis, and we're trying to address that with maintenance strategies on a clinical trial, and coming up with ideas in terms of how we can address that. Unfortunately, a lot of the myelofibrosis patients are excluded from a lot of the maintenance trials. So we're trying to develop trials that would be specific to myelofibrosis to address the high risk of relapse, which has been seen in our study and also across other studies describing transplant and myelofibrosis.